Okay.
I start now the recording. Okay, thank you. نبدأ الآن. السلام عليكم ورحمة الله وبركاته. مساء الخير أخواتي وأخواني الأعزاء، لكم على مشاركتكم ندمتنا لهذا اليوم اللي راح تكون على أمراض المفاصل وروماتيزم. ممكن قبل ما نبدي أنه أسأل الأخوان جميعا والأخوات أنه يخلون مايكروفوناتهم على ميوت حتى يكون تسمعون أحسن. بالنسبة للأسئلة والأجوبة يعني يمكن تكتبوها على جهة الشات. أنا راح أجمع الأسئلة وفي نهاية المحاضرات راح نطرحها على الأخوة المحاضرين حتى ينطوكم الجواب، إذا لكم أي استفسار أيضا. ندوتنا اليوم هي عن أمراض المفاصل والروماتيزم. اختارينا باقة جميلة من أطبائنا العراقيين استشاريين المفاصل من العراق ومن الإمارات العربية المتحدة ومن بريطانيا، يتكلمون عن مواضيع لكن نشوفها مهمة جدا في هذه الفترة. بس أحب أذكر أنه الموضوع القادم راح يكون الجمعة القادمة هو عن الريسيرش وهو تريد أو critical reading of papers وهم كيف تنشر البيبرز أيضا. وأيضا راح يكون بروفيسورز من بريطانيا ومن جنوب أفريقيا أيضا ساوث أفريقيا. واللي الأسبوع اللي بعده راح يصير يوم سبت مو الجمعة، راح يصير على عمليات السمنة. متحدثي الأول في لقاء اليوم هو الأخ العزيز الدكتور شبيب أحمد المظفر، وهو خريج بغداد سنة 1998 وزميل كلية الأطباء الملكية البريطانية FRCP، ويعمل حاليا استشاري أمراض مفاصل في جنوب ويلز في المملكة المتحدة في بريطانيا. عنوان محاضرته ستكون What you need to know about myositis. مثل ما ذكرت، إذا عندكم أي سؤال ممكن تكتبوه على الشات سايد. دكتور شبيب عيني الميكروفون لك، وشكرا جزيلا على حضورك اليوم.
ألف شكر دكتور رافد، السلام عليكم جميعا، وألف شكر مجددا على التفضل بدعوتي للمشاركة برنامجكم لهذا اليوم، وإن شاء الله تستمر هاي اللقاءات المفيدة العلمية لما فيه الخير للجميع. وألف شكر أيضا للإخوان المشاركين بهذه المحاضرات اليوم. فإن شاء الله أبدي بالمحاضرة مالتي. What you need to know about myositis. طبعا myositis عندنا there are different types or causes of myositis. فيعني I'm going to concentrate more today about idiopathic inflammatory myopathy. ويعني راح استخدم هذا الترمز أكثر عدة مرات لهذا اليوم. IM idiopathic inflammatory myopathy. فهذا يشمل عدة أنواع. فأول شيء عندنا dermatomyositis. Second one is clinically amyopathic dermatomyositis, which is dermatomyositis but without muscle disease. Then we have polymyositis, overlap syndromes, antisensitase syndrome, immune-mediated necrotizing myositis, and inclusion body myositis. So I'm going to talk about each one of them, starting with, before that, we start with the epidemiology. So incidence of IIM, idiopathic inflammatory myopathy, is of up to 10 new cases per million per year. وإن كان يعني other studies give you يعني higher incidence. Peak age 50 to 60 years, but it may
عفوا دكتور شهيد، تحب تشارك المحاضرة مالتك البرزنتيشن؟ لو عندك presentation you want to share or not, because we cannot see now the presentation.
العفو يعني you can't see my presentation, sorry.
It is not shared yet. Yes, sorry. Can you just if you
العفو بس من جديد share screen آسف.
Yeah, we can see it now. Go to slideshow now, please.
Just the slideshow is not allowing me to go. Sorry, just 1 second. Yeah, from start. Okay. Sorry. آسف جدا يعني it wasn't sharing. فمثل ما تكلمت في we have different types of idiopathic inflammatory myopathy. We have dermatomyositis, clinically amyopathic dermatomyositis, polymyositis, overlap syndromes, antisensitase syndrome, immune-mediated necrotizing myositis, and inclusion body myositis. I'm going to talk briefly about each type. Epidemiology is the incidence of up to 10 new cases per million per year, with a peak age of 50 to 60 years, but it may start at any age. We have cases of juvenile dermatomyositis. So dermatomyositis, idiopathic inflammatory myopathy in general, they can start at any age. Female to male ratio of 2.5 to 1, and in inclusion body myositis or IBM is actually commoner in male than female. Dermatomyositis is usually is a progressive symmetric. It causes progressive symmetrical proximal muscle weakness, and symptoms are usually over 3 to 6 months. So patient will come to you and they report history of say several months history of proximal muscle weakness. While children and young adults with dermatomyositis may have even more acute onset. This typically causes increase in serum creatine kinase, abnormal electromyography at muscle biopsy showing inflammatory infiltrates, and it usually involves other organs, for example, skin, lung, heart, gastrointestinal tract, and joints. Regarding the skin manifestations of dermatomyositis, as you can see, there are different manifestations that can be associated with dermatomyositis, but one of them is pruritus, which is very common actually in dermatomyositis. Gauthran's papules or sign, as you can see here, it's like raised papular lesions, erythematous or violaceous color, usually affect the dorsal surface of the joint, especially around the PI, proximal interphalangeal joints, and metacarpophalangeal joints. And then we have also, I'm just sorry, not one. Yeah, we have also Hollister sign and Shawl signs. I'll come back to them in a minute. I'll show you their picture. And also Heliotrope rash, mechanic hands, livido reticularis, nail fold telangiectasia, periingual erythema, non-scarring alopecia, cutaneous calcinosis, and cutaneous ulceration. So as you can see, there are different manifestations there. I showed you the Gauthran papule, and now we have the Heliotrope rash, which, as you can see, can affect usually lesions, erythematous or violaceous in color around the upper eyelids. And also we have Hollister and Shawl signs. Hollister signs is usually erythematous rash around the hips, and thighs, and Shawl signs is usually a rash that affects the upper part of the chest, neck, and upper part of the back. These are typical skin manifestations that we can see in dermatomyositis. And also we have the one that I mentioned, mechanic hands. It's usually caused cracking and thickening of the skin of the fingers, which is typically associated with antisynthetase syndrome. With regard to other manifestations of dermatomyositis, now we have the lung involvement. We spoke about the skin disease. Now we have lung involvement. So interstitial lung disease, or ILD, occurs in at least 10% of patients with dermatomyositis and polymyositis. And actually other studies can give you even higher rate, and some postmortem studies gives you even much higher figure actually. It's more often seen in antisynthetase syndrome and overlap disease. And restrictive lung disease can be seen due to weakness of respiratory muscles also. We have joint manifestations that can be seen in dermatomyositis, for example, arthralgia, arthritis that is usually non-erosive and affects the small joints. And it's commonly seen in antisynthetase syndrome. The one that I mentioned can be associated with mechanic hands. We have cardiac disease, which is relatively common in dermatomyositis patients, but it's rarely symptomatic. It can cause congestive heart failure, conduction abnormalities, myocarditis, and coronary artery disease. And we have gastrointestinal tract involvement, which is mainly in the form of dysphagia, which is affects about 1/3 of patients in IBM, or inclusion body myositis. And occasionally it can lead to aspiration pneumonia. Reflex symptoms can be also associated with dermatomyositis, and diarrhea and constipation. We have other manifestations. For example, systemic vasculitis it's commoner in childhood dermatomyositis, or the juvenile one, rather than in adults. And we have the renal disease, but it is unusual actually in dermatomyositis. This is an important association between malignancies and idiopathic inflammatory myopathies in general. So there's increased risk of cancers, especially with dermatomyositis. And this can happen in a significant minority of patients. So there's increased risk of lymphoma, lung, ovary, breast, colon cancers, and other cancers. And personally, I've seen it in patients with the breast cancer, cervical cancer, colon cancer, and patients with, I think, laryngeal cancer also. So definitely when you have a presentation of dermatomyositis, always go and take thorough history and do detailed examination, and you need to look and investigate for any possibility of associated or underlying malignancies. The risk is highest in the first 3 years of diagnosis, but it can persist for more than even 10 years after diagnosis. So it's not only when you diagnose dermatomyositis, but the risk can persist for several years after the diagnosis. So we spoke about dermatomyositis. We mentioned about all the associated features, but we have then another type of idiopathic inflammatory myopathy, which is polymyositis. This condition can cause proximal muscle weakness, but no cutaneous manifestations. So you have similar picture, for example, to dermatomyositis in terms of muscle disease, but no skin disease, no skin involvement. We have inclusion body myositis that it affects more men than women, and especially in patients over 50 years. So this condition is uncommon, and in young patients. It's usually caused insidious onset of muscle weakness, and usually I mentioned about dermatomyositis symptoms patient can present to you after months of with symptoms, but in particular with inclusion body myositis, patients tend to have much longer history at the time of presentation. And in addition to the involvement of the proximal muscles, it can involve the distal muscles, in particular the finger flexors. And I'll have pictures and I show them to you in a second. So this is also important. When you have patient with myositis, you don't only examine proximal muscles, but also examine the distal muscles, including even the fingers. And as I've said, dysphagia can happen in 1/3 of patients with inclusion body myositis. So this is typical inclusion body myositis. Patient can't make full fist. And also sometimes they can have even asymmetric finger flexor weakness, as you can see from this picture. I'm going to talk now about two more types of idiopathic inflammatory myopathy. One of them, antisynthetase syndrome. This has been identified in patients with autoantibodies against synthetases. The most frequent antibody is anti-Jo1. And clinical features of this syndrome includes myositis, Raynaud's phenomena, non-erosive symmetrical polyarthritis, usually involves the small joints, and mechanic hands, the one that I showed you the picture. So when you have patient with myositis and they have arthralgia, especially of the small joints of the hands, background history of Raynaud's, just examine their hands. Many times you can see mechanic hands, and also it can be associated with higher rate of interstitial lung disease. We have another type here that we call it immune-mediated necrotizing myopathy, which is clinically similar to polymyositis, but the severity of muscle necrosis and the lack or the presence of only few inflammatory cells on muscle biopsy distinguishes it from polymyositis. It can be associated with certain myositis-specific antibodies, as I'll show you in a minute. And many times you can see a history of statin use in such patients. So when you have patient with myositis, always ask about any history of statin use, as the presentation can be secondary to immune-mediated necrotizing myopathy. This is, as you can see, I'll show you the difference between inclusion body myositis and polymyositis. So inclusion body myositis, it affects more male, while polymyositis actually affects more women. And the age in inclusion body myositis outset is uncommon before 50, while with polymyositis is common before 50, can be seen in any age group. And the presentation is, the onset is very insidious in inclusion body myositis, while it's acute or subacute in polymyositis. The course, as I'm going to show you cases at the end of this presentation, is slow progressive inclusion body myositis, while in polymyositis is more rapid. The weakness in polymyositis, as I've said, it affects proximal muscles, while with the IBM, it can affect proximal and distal muscles. Creatine kinase, which is the main test that we use for such patients when we investigate for myositis, a blood test. So it can be normal or less than 10-fold of normal in IBM, while it is in many cases more than 10-fold the normal in polymyositis. And also we talk about muscle biopsy in a minute, about the different features in muscle biopsy. With inclusion body myositis, from the name, we can see inclusion bodies under electron microscope, and we can see also rimmed vacuoles, and this can differentiate it from other types of myositis. So always, if possible, to do a muscle biopsy. And the response to therapy in IBM generally is the response is poor, while in polymyositis, it depends on other factors that we talk about them. I'm not going to talk about all of these conditions, obviously, because we have other lectures, obviously, today. But there are other causes of myopathy in general, or different types of myopathy. So we spoke about the inflammatory one. We have other causes. For example, when you have any patient presented to you with suspected myositis, always we need to rule out other conditions. So there are endocrine disorders, especially the hypothyroidism, Cushing syndrome. We have electrolyte disorders, metabolic myopathy. We have drugs and toxins. We have corticosteroid. It can be associated itself with myopathy. We know corticosteroid, glucocorticoids are treatment for myositis, but long-term steroid can be associated with myopathy. Other medications, in particular colchicine, hydroxychloroquine, and statins, as I've mentioned. And also infections can be associated with myositis, and different viruses, including COVID-19, that we know can be associated with myositis. And inshallah, Dr. Athir will talk about it. And also rhabdomyolysis, always good. We need to rule out this condition when we have any patient with suspected myositis. And in addition to inherited myopathies, they are always in the differential diagnosis. So investigations, when you have a patient with suspected myositis, what we need to do, we will do routine blood tests. Obviously after taking full history, detailed examination, then do blood tests. For example, complete the blood picture or full blood count, UNEs, the urea electrolytes and creatinine, liver function test, bone profile, then also inflammatory markers and thyroid function tests. These are very important to be done. And also we check vitamin D sometimes. Muscle enzymes. So CK or creatine kinase is the most useful enzyme for diagnosis and assessment of patients with myositis. It is specific for skeletal and cardiac muscles, and raised CK is not specific for myositis. So when CK is raised, doesn't mean it's always myositis. And again, CK levels are not always raised in myositis. There are other enzymes, say LDH, myoglobin, and ALT can be raised in myositis, but they are and LDH and ALT are not muscle specific. In terms of other investigations, we do the autoantibodies. The first one we do is ANA, which can be positive in up to 60% of dermatomyositis or polymyositis. And we have myositis-associated antibodies, for example, anti-Rho, anti-La, anti-SM, anti-RNP, all of these autoantibodies that can be associated with other rheumatic diseases that can be associated with myositis. So these, we call them myositis-associated antibodies. And then we have next myositis-specific antibodies. These can be associated with specific clinical phenotypes and can be seen in up to 40% of IIM. There are different myositis-specific antibodies. We can have anti-synthetase antibodies, and the commonest one of them is anti-Jo1, and especially is associated with interstitial lung disease or ILD. We have anti-MI2 antibodies, which are usually associated with acute form of dermatomyositis with the cutaneous manifestations. Anti-MDA5 antibody, which is associated with ILD and higher morbidity and mortality. And we have anti-SRP that can be associated with necrotizing myopathy. And patients tend to have severe disease with very high CK. And likewise, anti-HMG-CoA reductase, it can be associated with the statin use, and again, can give you necrotizing myopathy. So as you can see that we have we check ANA, we check myositis-associated antibodies and myositis-specific antibodies. Sorry. Yeah, and I mentioned to you about investigations for underlying malignancy. So always when we have patients, like a lady with dermatomyositis or myositis in general, always good idea to do breast examination to make sure that there is no breast cancer, or investigate for this condition also. I personally do, we do CT thorax, abdomen, and pelvis for any patient with myositis to look for any underlying malignancy. Obviously, other investigations depends if the patient, one patient I mentioned to you about laryngeal cancer, obviously this needs to be investigated accordingly, or any cervical problem, so on. So it depends on the underlying problem or symptoms, but at least just to do CT thorax, abdomen, and pelvis in such patients. We do electromyography or EMG, which can be very helpful in the diagnosis, and more than 90% of active myositis tend to have abnormal EMG. So having normal EMG, this makes the diagnosis of inflammatory myositis less likely. We do MRI, magnetic resonance imaging, and this can differentiate between normal muscles, edema secondary to inflammation, and also can show you the muscle fibrosis. It can allow us several muscles to be investigated at the same time. But however, it's non-specific and sometimes can be difficult to differentiate between inflammatory myositis and, for example, rhabdomyolysis on MRI. Here are some pictures, you can see for MRI scan, for example, the normal one, the top one, the top two pictures, and then we have the, for example, in IBM or inclusion body myositis, you can have abnormal muscles. With the stir sequence, this one that we suppress the fat, but at the same time can enhance the edema or inflammation of the muscle. So you can see the brightness there in the muscles, which can indicate myositis. With regard to the other investigation that's very important is muscle biopsy, which remains the gold standard for confirmation of idiopathic inflammatory myopathy. And all the types of inflammatory myositis show you variable degree of changes, but they include muscle fiber necrosis, degeneration, regeneration, inflammatory cells infiltrate, and certain features. I mentioned to you about inclusion body myositis. You can see on the picture on the right side with the black arrow here, you have some vacuoles there, and also you have the inclusion bodies in the cytoplasm can be seen in this picture under electron microscopy. Treatment of IIM, it depends on the cause. In general, inclusion body myositis is non-responsive to glucocorticoids, while overlap myositis is the most likely one to respond to steroid. Starting dose of steroid is prednisolone orally is usually 1 milligram per kilogram daily, and we prescribe up to 80 milligram daily. We prescribe IV methylprednisolone pulse, 1 gram daily for 3 days. We give it initially in severe myositis. This is before we start the oral prednisolone. And we aim to taper the prednisolone to the lowest effective dose over the next 9 to 12 months. Physiotherapy, rehabilitation, they have very important role for our patients, as can take long time for symptoms to improve, weeks, if not months, and actually several months. So they need to have physiotherapy at the same time. Don't forget about bone protection while on steroid, say to give oral bisphosphonate. If there's no contraindication, give calcium and vitamin D daily because of the risk of associated bone loss on high dose of steroid. And also with stomach protection, stomach lining protection, we give also a proton pump inhibitor, for example, omeprazole while on steroid, especially when they are on high dose. We prescribe also steroid-sparing agent at the same time of starting glucocorticoids, and we have the choice between methotrexate and azathioprine. Both are good options that we try at the same time of initiating the prednisolone. And say with methotrexate, we start with 15 milligram weekly, and then we increase the dose up to 25 milligram weekly. And azathioprine, we start with 50 milligram daily, and we increase the dose slowly. For resistant disease, we consider the use of rituximab or IV immunoglobulins. Rituximab is the best option here, but we have other options that can include mycophenolate mofetil, cyclosporin, and cyclophosphamide. For IBM, inclusion body myositis, as I've said, is there's no effective treatment. It's relatively resistant to standard immunomodulatory therapy, and the aim is to optimize muscle function and strength in patients with IBM. We can consider immunosuppressants for such patients, especially when they have atypical presentation, when the CK is very high, and in patients when they have associated systemic autoimmune disease. I'm just going to before that I just talk about the prognosis. We have the predictors of prognosis in dermatomyositis and polymyositis. These include the specific type of myositis, the pattern of the disease severity, the delay in diagnosis and starting the treatment. You know, when you start the treatment after several months, this can affect the response to the treatment, and the prognosis can be poor at the end. The presence of certain extramuscular manifestations, especially interstitial lung disease, and also the antibody profile, all of these can affect the prognosis. The 5-year survival rate from the time of diagnosis is worse for cancer-associated myositis, approximately 55%, while more than 95% of dermatomyositis and polymyositis are still alive more than 5 years after diagnosis. And IBM progresses faster to disability when symptoms begin after the age of 60. I know we are just tight with regard to the time, but I just have three cases very briefly, that they are all real cases that I'm going to talk about them if time allows. So we have the first one, 24-year-old lady with history of asthma, eczema, and obesity. She's actually under rheumatology for mixed connective tissue disease based on arthralgia, Raynaud's, strongly positive ANA, and strongly positive NTR and P antibodies. And she was only on nifedipine 10 milligram BD hydroxychloroquine, pregabalin, and omeprazole. So young lady with mixed connective tissue disease, but in January this year, she reported 4 weeks history of general weakness, difficulty in going upstairs and standing up from sitting position. She's well otherwise without any recent infections. System examination was unremarkable, but she was weak proximally in her lower limbs with power 3 out of 5. CK was very high, nearly 10,000, and you can see upper normal depends on the lab, but in our lab it was up 200. And ALT was raised at 163. Her other investigations were fine, including full blood count, UNEs, bone, CRP, thyroid function test, and vitamin D was very low in her case. Myositis specific antibodies were negative, and urine dip was negative also. Urine test was negative. CT thorax, abdomen, and pelvis was normal. And she did have MRI scan of the thighs, which showed diffuse muscle edema in keeping with active myositis. So we diagnosed her as overlap syndrome. So inflammatory myositis in the setting of mixed connective tissue disease. She had IV methylprednisolone pulse, 1 gram daily for 3 days. And then we started her on prednisolone 60 milligram daily and azathioprine, 50 milligram daily, and those to be increased over the coming weeks. Muscle biopsy was done, but not reported yet. It was done a few days ago. And actually her CK was 2,100 3 weeks after starting her on the treatment. So it has come down from nearly 10,000 to 2,000 after 3 weeks of treatment. Second case is 65-year-old lady with background history of hypothyroidism and androgenetic alopecia. She's on levothyroxine. She was seen by rheumatology for the first time in 2012, following a referral from dermatology, at that time with positive ANA and strongly positive NTRO and NTLA antibodies. And apart from alopecia, at that time, she did not have any other connective tissue disease symptoms, and labial gland biopsy was arranged by one of the rheumatologists, was not supportive of Sjogren's syndrome. So she was discharged back to her general practitioner in 2013. But then again, she was referred to us this time by her GP at the end of 2019 for muscle weakness and raised CK of nearly 500. And sorry, just the slides are not moving. Yeah, okay. So she described, when we saw her, she described at least 5 years history of slightly progressive lower limb weakness with difficulty in climbing up the stairs and standing up from sitting position. But there was a letter from the dermatologist from February 2012. At that time, it mentioned in the letter, strength and mobility has reduced, and she has some problems getting up off the floor. So clearly she did have some weakness, muscle weakness at that time, even in 2012, but her symptoms have progressed slowly over the years. She's able to walk for few miles, like for 5 kilometers daily without any difficulty, but the problem is always in going up and up the stairs in particular. She reported also intermittent difficulty on swallowing dry food since 2012. There was some dryness of the mouth occasionally, but no dryness of the eyes and no salivary gland swelling. She did not have any skin rashes or joint symptoms. She did not describe any other symptoms, for example, weight loss or chest or bowel symptoms. System examination was unremarkable. She did not have any muscle tenderness or rashes. Power was normal in her upper limbs, except minimal weakness of the grip bilaterally. You remember I showed you a picture there of the hands, and I think it looks in her case more as the first picture. She was unable to make full fist. Power was normal distally in her lower limbs, but it was 4 out of 5 in her lower limbs proximally. So you can see just mild proximal weakness, but she's been having these symptoms for several years. She had a blood test, as you can see. ALT was slightly raised. CK has been raised on multiple occasions since 2012, with figures from 369 up to 675. So it's only mildly raised, always less than 1,000, unlike the other patients that I showed you. Her other investigations were fine in terms of thyroid function test, HbA1c. Her ANA was positive, anti-Rho, anti-La again were positive. Rheumatoid factor was significantly positive. Anti-CCP antibodies, anti-phospholipid antibodies were all negative. So she did have MRI scan of the thighs, which showed localized myositis, but there was no evidence of myositis in the upper limbs. CT thorax, abdomen, and pelvis was unremarkable. EMG showed features in keeping with a myopathic disorder, and muscle biopsy showed findings highly suspicious of inclusion body myositis. So with this patient, she's had several years history of slowly progressive weakness in her lower limbs, mildly raised CK over the years. Muscle biopsy confirmed the changes of inclusion body myositis. So we didn't start her on systemic treatment. We referred her to our physiotherapist, occupational therapist, and we are seeing her regularly. This condition, as I said, is relatively resistant to standard immunomodulatory therapy. The last case of a 72-year-old
دقيقة واحدة وقت.
أي نعم أحسنتم. This patient referred to us by hematology with raised CK. He was on simvastatin for 10 years. Originally seen by hematology for a progressive muscle weakness, weight loss with peripheral blood lymphocytosis. But they did several investigations on him, and they felt his lymphocytosis is reactive rather than leukemic. So CK, they checked the CK, it was raised, and they referred him to us. So when I saw him, patient reported 6 months history of difficulty in lifting his arms overhead and climbing stairs, some weight loss, and system examination was unremarkable, and he did have mild weakness proximal in his lower limbs. The main abnormalities on his blood test was leukocytosis, with lymphocytosis in particular, as you can see. ALT was raised, CK again was more than 3,000, and LDH was raised. His immunology blood tests were all negative. And CT thorax showed prominent iliac and retroperitoneal lymph nodes that are non-specific. And MRI thighs and upper limbs showed diffuse myositis. And muscle biopsy, unfortunately, was not done because of COVID-19. So we diagnosed him with inflammatory myositis, started him on prednisone 40 milligram daily with methotrexate. And after 6 weeks of a treatment, we saw him in the clinic. Power was normal all over, CK very close to normal at 355 with normal ALT. So thank you very much for listening. I'm sorry for the delay. Sorry for يعني بقيناكم شوية متأخر عن الوقت. آسفين. شكرا جزيلا للاستماع.
شكرا جزيلا دكتور شبيب.
وأنا حاضر إن شاء الله لأي أسئلة.
Could you please stop sharing the screen so we can
Okay.
start the second speaker? No, still. If you go to the share screen and just stop share, click on stop share. You know the
Pause share.
yeah, the green arrow. Yeah, that's good. Thank you.
Yeah.
Thank you very much indeed.
شكرا جزيلا.
شكرا دكتور شبيب. المتحدث الثاني هو أخونا العزيز أثير الأنصاري. أثير هو consultant rheumatologist UK trained. He got his CCST وشهادة الاختصاص في عام 2008 and he worked as a consultant and head of department at Hollywood Rheumatology in Telford. He moved to Abu Dhabi in 2013 with the same position. He's working now at Mediclinic Airport Road Hospital in Abu Dhabi. He's a board member of Emirates Academy for Rheumatology, ERA, from 2019 till now. He's ex-vice president of the Emirates Society for Rheumatology from 2016 till 2019. He's head of scientific committee for annual Asian and Pacific Rheumatology Conference in 2017, Dubai. He shared in various conferences, talks and publications, articles and committees. He contributed with lectures in Baghdad, Erbil and London with the United Iraqi Medical Association. طبعا هذا جهد يشكر عليه دائما، هو من المتطوعين الأوائل للمشاركة في مؤتمرات الجمعية. شكرا جزيلا. الميكروفون ناو الأخ العزيز دكتور أثير اللي راح يتكلم عن دور الروماتولوجيست في management of the COVID-19.
شكرا جزيلا دكتور رافد على هاي المقدمة. I'm going to share my screen. Right. I have chosen this topic because it's a hot topic and why rheumatologists need to get involved in COVID-19. A year ago when the outbreak emerged and we thought it's viral infection, infectious, go to respiratory system, severe, go to ICU. Rheumatologists don't play any part in this apart from personal protection. However, time after time, there are events happening, led rheumatologists, and particularly me, to some sort of discussion and action. And eventually, I get heavily involved in COVID-19 at some point. And I still do recommend rheumatologists to get involved. My contributions usually appear in Facebook, the people who follow them, and I include some narrations as well as some scientific evidence. So this is rather unorthodox presentation. We started with one of the studies, very biased study, someone say hydroxychloroquine could minimize the infection with COVID-19. However, that perpetuated around the world as, you know, as a fire in the jungle, and everybody talking about that, led to the point that everybody prescribed hydroxychloroquine. People save it at home. Colleagues come to me asking for a prescription. And there is, this study is poor and no good evidence for that. And this GP, if you know, in America was crying in an emotional way how their patients are having hydroxychloroquine with no one had get the coronavirus. We cannot take the statistics or the conclusion that way. This is very naive. And we had to get a reply from a rheumatologist. I say, this is not the way you tackle statistics or epidemics. You had to have randomized controlled trial. So the first lesson here I put there, don't take a message coming for the first time. We only put things in practice when it is repeated in 2-3 studies before we say, look, yes, this could be true. Well, what happened there is an outcry and it's crazy thing affecting our rheumatology patients. And that's the story. That's the first study which appeared. French study in Marseille also claimed it minimized the severe. It was only small 20 patients. How you can conclude something globally on a very small study? So this drives us very, very crazy as rheumatologists. What hell is going on? And then Donald Trump, not impeached till now, he made the most crazy status of having hydroxychloroquine push on the FDA on a political ground to approve it for urgent use. And the word was desperate, fair enough, all right? But how we use it in combination with antiviral. But putting this, you didn't believe the number of people believe presidents more than believe rheumatologists on this. So this is a study by March 2020 showing that there is no good or robust evidence that hydroxychloroquine, when you have theory that it could block the receptor for the virus or could have any mode of action, this is a theory. You have to apply it in a practical way and you will see that they are benefiting. We have a lot of theories around, but we cannot take every theory to put our practice on because the practice might show the theory is wrong. So that is another message I wanted to put today. And we have Rheumatology Alliance real world data. Nobody took our data. This is Alliance from Rheumatology group. And we have a 25% of that group taking hydroxychloroquine. The rate of infection, the severity of infection is no different to the general population. This is a real world data telling us hydroxychloroquine play no part in the protection against COVID-19. Doesn't matter what theory they put on the lab. What happened that we had shortage of the medicine and our patients who are rheumatic patients are struggling to get their medicine. So globally, there is more harm than good done by this practice. And this is because taken on one very biased, uncontrolled study. And this practice has to be carefully judged before the world go crazy about it. Even my pharmacist, he started to give all Plaquenil hydroxychloroquine to his friends, and my patients who don't get that. And he was refusing my opinion on discussion. That's why I needed to get involved again and again. Help came from nowhere, as one of studies showed, hydroxychloroquine caused cardiac toxicity. This is, again, I've been prescribing hydroxychloroquine for 20 years. I haven't heard this before. If anything, it's very rare. Doctors then slowed down prescription, so the drug became available again. However, my rheumatic patients stopped taking the medicine because they are scared of cardiac toxicity. I don't want to offend anyone, but I just find this meaning is there. إن جاءكم باحث أو ناشر ببحث فتبينوا قبل أن تصيبوا قوما بجهالة. This is going mad around the world, and everyone publish anything and everyone take it and goes like a fire in the jungle. We shouldn't practice like that as doctors. We have to be careful and rational. And so our cardiologists, please, they tend to stop anyone with any palpitation, stop their hydroxychloroquine. Cardiologists, please don't stop hydroxychloroquine. It is safe. Safe, that's a study published in the American College for Rheumatology Convergence, and it's clearly showing that hydroxychloroquine do not prolong QT interval or do not cause any sort of cardiac toxicity. So please, cardiologists, keep our patients on their medicine and don't stop them. Come to the vitamin D. Again, there was a very big thing about vitamin D because of Spanish study and said there are people with low vitamin D have worse COVID infection and this sort of thing. However, that was retrospective epidemiological record. Again, when you come to any theory, with any theory, you have to prove it practically by randomized controlled trial. And thankfully, Professor Neil Gittles They did the trial of supplement. Vitamin D did not make difference to the outcome. This vitamin D issue, I had a full lecture of vitamin D. This is a side dish information today. Unless you prove supplement help that condition, vitamin D play no part in the causality of diseases, even like diabetes, hypertension, or cancer. On the contrary, it could be the result of these conditions because supplement do not help these conditions. So thankfully, this evidence we start to distribute. Please don't give vitamin D. And I don't know anything about zinc or magnesium. People used to take it for this COVID-19. The world is desperate. I understand that, but there is no evidence. Let's come to the real science. What is happening? Now, the first model of what is happening in COVID-19 infection is this model. There is a viral phase, and this viral phase, then it triggers immune response, and the immune response suddenly bursts like a hurricane, and then start to cause damages. This is the first understanding of this type, so we know there are two phases. When we treat viral phase is one thing, okay, get rest, take Panadol, and if you treat the later phase is another thing. So how we go about that? So that is the phase, that's when there is a, let me say, a quick or a steep rise in the inflammatory markers, which I'm going to elaborate on that. I'll go quickly because of the time. So the main cytokines or inflammatory markers, IL-6 play the biggest part in this, and all sorts of inflammatory markers have risen. And the sequelae of that is increase in fibrinogen, fibrin degradation, and fibrin clot. So there is a clotting sequelae of the process. So the process is that so complex. The findings on a clinical ground, there is very high CRP, ESR, D-dimer, platelets, fibrinogen. If you look at that and people with the systemic symptoms, you start to think this is similar to active systemic still's disease. And now they call it multi-systemic inflammatory syndrome. C syndrome, pediatricians prefer that description, different from Kawasaki. So here, when you talk about systemic inflammatory disease, it's a good reason for a rheumatologist to play part in the management of these conditions, because this is our game. This is a busy slide, but if you look, 5% of severe COVID infection could develop systemic dysregulated cytokine response. And if we go to the right of the slide, IL-6 is the key marker, is the highest proportion compared to other markers, including TNF, interleukin-1, interleukin-8, and so on. So this is the major player. However, on this model, they try to say early detection of inflammation markers is the key in the management of COVID-19 cases. And if you can be ahead of the cytokine storms, just like preventing the serious disease. So this is one of the key messages in here. And what we have done proved success because we looked at these 2 points. So if you have cytokine storm and somebody already has some damage like diabetes, a bit of cardiac disease, a bit of lung disease, when they have cytokine storm, can be just damaging, can be fatal. What we are trying to do is to stop the cytokine storm. So the first biological study was done in China on tocilizumab. Tocilizumab is interleukin-6 inhibitor. We treat rheumatoid arthritis, we treat vasculitis with it, but we never thought to treat an infective process to our first understanding like that. Because of high CRP and high ferritin, and female Still's disease also have very high ferritin, so there is similarity there. It was a small study, just handful number of people. However, there is substantial response to tocilizumab. So the China included in their protocol to give people with a high IL-6 level tocilizumab adapted quickly by UAE. I have been putting this in my Facebook as advice to colleagues. However, at that time, US and UK were still counting the fatalities to compare it to the Black Death in the medievals. The other study confirming that concept is that treating IL-6 with IL-6 inhibitor minimize IL-6 and CRP and improving people going into mechanical ventilation. As this is one perhaps a clinical outcome you are looking for. we are repeating this slide, sorry. So I published this in my Facebook as a case because we had some argument with colleagues about how tocilizumab, how good or bad. So I presented this case. She is a rather young lady, presented COVID positive with fever, shortness of breath in May 2020, admitted. She became negative for PCR, but still symptomatic, still in the hospital with high inflammatory markers. So when I've been called by my colleague, Dr. Abdullah, we gave her tocilizumab, we decided to give her tocilizumab for that reason. And the main thing here, we are not treating the virus, and she became PCR negative, as I said, but we are treating the immune response. So the immune response is our game as rheumatologists. We deal a lot with inflammatory immune response. So when we gave her tocilizumab, this lady improved within 2 days and discharged home, and all her symptoms disappear. And I'll show you the figure of the case. But here I put under the line, we should treat COVID sequelae, just like rheumatoid or lupus, with immune moderator, not hydroxychloroquine and not vitamin D and not other items. Even antivirals, I'm not sure they play a big part. So this is the X-ray of the lady. She's in her like late 20s. And that's on the scan, how it showed how multiple inflammatory area. This is not pneumonic patch, it's not bacteria. This is inflammatory with a ground glass appearance, acute alveolitis type picture. And after recent COVID, you can only assume this is an immune mediated. These are maybe not very clear because it's from my mobile, but the CRP went up and up and up till has treated on the 14th of May, I think, then the CRP went down. Similarly, ferritin level went down. It was high for 100, the normal level is less than 200, then is improved. Similarly, the D-dimers also improved after being high at a later stage. And I'll mention this later stage, what it means. Also, platelets are getting higher at later stage, but improve later on. This is her X-ray compared to the previous X-ray above. And this lady is very happy on discharge. And as I said, we had around 24 patients out of 26 have a substantial benefit from tocilizumab. It could be in the series, could be the highest in the world. But why? Because any patient, we used to admit patients even at less than symptomatic level or very mild. Every day, I ask the internist to check fibrinogen, ferritin, and CRP every day. Whenever on the next day there is a surge, CRP move from 20 to 80 or 100, I say, give tocilizumab now. That is the key, that to stop the cytokine storm. That's the lesson of the day I wanted to put there. When people say someone critically on an ICU gave them tocilizumab, it doesn't work. Of course it doesn't work, it's too late. We need to give tocilizumab at this surge of the immune markers. This is the controversy. When we did our work, there was a second study in Italy. So if we couldn't believe just the China, Italy also came to the same conclusion. Netherlands similarly have this study, but a study in UK and study in other parts of the world, they put tocilizumab to the mix, either very early or very late. Of course, the figures will not be that robust. You need to give it in the cytokine before just the cytokine storm or at the cytokine storm beginning. That is the main question, is when to give it rather than just to give it. So there is a good study when you give methylprednisolone with it as well. And I'm talking about the steroid in COVID in a minute. But there is a good likelihood that they respond at the same time. For the steroid, because there is conflicting data, steroid may be not a good thing if you are before getting COVID-19 infection, as it might suppress some T cells. But when there is immune response, steroids is the most helpful one to give it with tocilizumab. So that is different in the meaning about the steroid. So this is the model. We'll explain the COVID-19 phases. So if we give the tocilizumab at the cytokine storm phase, we could minimize the damage caused by the further phases, coagulation phase or the late hyperimmune inflammatory phase. This lady, perhaps we've seen them on the 4th phase, but what I'm worried on the 3rd phase, coagulation phase, because we've seen many people improved, asymptomatic, PCR negative, and we have 2 cases, went home and then suddenly collapsed and dead. And that was the coagulation phase. They end up with a PE. And this is an important message today, is that everyone cleared from COVID-19 to take 3 to 6 months anticoagulation, just to avoid this type of sudden death. Other studies are underway, sorry. There is baricitinib, which is a drug inhibitor, again have some IL-6 inhibitor effect. Anti-TNFs, we treat rheumatoid arthritis with them. Colchicine and anakinra, which has interleukin-1 inhibitors, all are underway to treat COVID cytokine storms. Technically speaking, we are talking about the hyper-inflammatory condition similar to Still disease, similar to Kawasaki, and now give it a name, MISC syndrome. They are variable success simply because TNF or IL-1 are not the very major factor compared to IL-6. The other aspect which I want to talk about is rheumatic medication with COVID. Most people, we feel very bad when our patient had advice from different specialties, stop this medicine or take this medicine or don't take vaccine or whatever you do. This advice should be from us, or if you want to hear it, you hear it from me and then you take it religiously. Most rheumatic medicine now, and this evidence perhaps evolved with time, they are not putting patient at high risk of COVID. Stop. New line. Only at the time if the infection occur, we stop them. But they are not putting patient on the high risk of infection simply because they are not immune suppressant. They are immune corrector, and I'll explain that in a minute. Most international guidelines now clearly putting this statement. This is a model about what is inflammation and how we measure inflammation in terms of cells activity, antibodies activity, cytokine activity. There is the normal level in a blue line, which is, this is the natural, could be up and down if you don't eat well, if you are depressed, or whatever, your immune system go up and down, that's a natural phase. The red phase is the hyperinflammatory phase that occur in most inflammatory conditions, uncontrolled. So if you have hyperinflammatory phase, uncontrolled, and you get COVID, this is a double blow, which means you get more and more inflammation and more sequelae of organ failure or clotting event or anything like that. So having rheumatic therapy for rheumatic disease is a must to minimize the hyperinflammatory state, to bring it down to the normal level. Our medication would not cause true immune suppression, which is the bone marrow suppression. Rarely, only cyclophosphamide and rituximab could be arguable. But these are the 2 medicines. The rest of the medicine, we monitor them very well and rarely we get bone marrow suppression. So they are, in fact, they are immune corrector, they are not immune suppressant. And the word immune suppressant is drive everyone mad in terms of patient get scared of it and they stop the medicine and the problem escalate further and further. So I wanted to elaborate on that. So when you go to your community, at least you understand what are these terminology. Plus, we need the patient good enough to tackle any requirement he needs for the self-isolation and protection. If they got painful hands, painful joints, they cannot really be independent and they need help, and that by itself is a risk. This model, I'm coming near the end. This model, when you give tocilizumab, how all markers coming down, similar to our case, the D-dimer sometimes last longer, and those are might having the risk of clot or DVT or the PE. So those people, plus I would say religiously, all of them to be given at least 3 months of anticoagulation. We know post-viral immune syndrome, we have many conditions. If you heard Henoch-Schönlein purpura, if you heard reactive arthritis, if you heard Guillain-Barré, they are all a response to a viral trigger. We do have more descriptions of vasculitis. We do have, as I said, in pediatric, we have the Kawasaki-like syndrome. And also there is a research showing the clotting event could be affected by a transient antiphospholipid antibody elevation that might put people at risk of a clot. So we need to take that in consideration as well. The last two slides is about vaccination. Again, we have a recent update from the American guidelines. Most people on the anti-rheumatic therapy can safely take vaccination. The worry at the beginning in case of the vaccine molecule, could it trigger the same immune response like the virus? But that's did not happen and is not true now. And we are happy to give vaccine to most of our patients. And this is the guidelines from the American. You see most of the anti-rheumatic therapy, no need to modify any modification or to vaccination timing. So most of them can take them freely without any concern in terms they stay on their medication and take the vaccine. I hope the vaccine will become available to all Iraqis soon. So that's the main point I want there. What I'm here, I'm only trying to put the right messages to all my colleagues in different specialties, not to offer any advice unwittingly that could harm the patient rather than help them. Refer to rheumatologists all the time. And thank you very much for listening. I try to be speedy because of the time.
شكرا جزيلا. Thank you very much indeed, Dr. Athir. Very
excellent
presentation. Thank you. A very good subject, very nice subject. Thank you very much indeed. I have a good number of questions now, but before that, we go to our third speaker.
Did I stop my screen?
Yes, it's okay. No, it's done now.
It's okay. It's okay.
It's okay. Thank you. دكتور عقبة نافع يوسف, consultant rheumatologist and lecturer at Tikrit University College of Medicine. He got a diploma in expert of musculoskeletal sonography from Barcelona University. And today he will talk about paraneoplastic polyarticulitis. موضوع غير تقليدي, موضوع جدا يعني مهم. هناك أمراض المفاصل تأتي ونشخصها مع الأسف بالخطأ كمرض مفاصل, ونكتشف بعد مدة أنه لها علاقة بسرطان. وهذا هو الموضوع اللي راح يتكلم فيه دكتور عقبة. طبعا دكتور عقبة أيضا شاعر, يكتب شعر بديع جدا, لكن إن شاء الله ندعيه في المنتدى الأدبي لإلقاء قصيدة من شعره الجميل.
شكرا.
الميكروفون لك الآن. شكرا جزيلا على المشاركة.
شكرا جزيلا على التقديم اللطيف دكتور رافد العزيز والإخوان الأعزاء المستمعين الكرام. أشكر دعوتكم الكريمة وأشكر الجمعية الموقرة.
شكرا لكم.
شكرا جزيلا حبيبي. كان أشير ماي سكرين؟
Yes, please.
Okay. Bismillah ar-Rahman ar-Rahim. My lecture today is paraneoplastic.
Still is not shared yet. Could you try again, please?
ما صار عندك
لا. Click on share first. You know, the green box. Yeah, very good.
Now, okay?
Yes, okay. If you put on the slideshow now. Yeah, excellent. Thank you.
Bismillah ar-Rahman ar-Rahim. My lecture today, paraneoplastic polyarticular arthritis. Introduction. Malignant disease may be associated with a wide variety of musculoskeletal syndromes by different mechanisms, and there are a complex bidirectional relationships between rheumatic diseases and cancer. Certain rheumatic disorders, including dermatomyositis, polymyositis, SLE, rheumatoid arthritis, Sjogren's syndromes, are associated with an increased risk of malignancy, and in some instances may be as a result of cancer-induced autoimmunity. In addition, treatment of rheumatic diseases, biological drugs, and chemical therapies might increase the risk of malignancy. So the concomitant presence of malignancies with rheumatic diseases may appear in various forms. First, metastasis to the musculoskeletal tissues. That's mean the essential neoplastic cells metastasize to the joints, to the synovium, to the connective tissue everywhere. This category could be seen with many malignancies, colonic cancer, adenocarcinoma of the lung, ovarian cancer, gastrointestinal cancer, and so on. 2, malignancies secondary to aromatic diseases. This is what Dr. Shabib mentioned, like dermatomyositis and polymyositis, and rheumatoid arthritis might be associated with malignant disease. 3, malignancies which is developed as a complication due to immunosuppressive drugs used for the treatment of rheumatic disease, and also rheumatic diseases which developed as a complication from malignancy treatment. The 5th subject is non-metastatic paraneoplastic rheumatic disorder, which is our subject today. Arthritis is one of a group of paraneoplastic rheumatic disorders. There is many paraneoplastic rheumatic disorders, but here arthritis is one of this group of disorders resulting from an underlying malignant disease, but it is rather than metastasis and not directly related to the tumor itself. Paraneoplastic rheumatic disorders characterized by 1, they must occur during the course of an identified malignant disease or precede clinical evidence of the malignancy. 2, the rheumatic symptoms are unresponsive to conventional treatment. 3, symptoms cannot be the result of direct tumor invasion or compression, and the symptoms might be improved with successful treatment of the cancer. Paraneoplastic rheumatic disorders firstly reported in 1916, and at that time heralded a malignancy, and there is many paraneoplastic rheumatic disorder. As I mentioned, arthritis is one of the most important paraneoplastic disorder and include carcinoma arthritis, hypertrophic osteoarthropathy, amyloid arthritis, secondary gout, and hyperuricemia. Vasculitis, paraneoplastic vasculitis, Raynaud's syndrome, and digital gangrene, erythromyalgia. Skin and muscle disease, dermatomyositis and polymyositis, scleroderma-like syndrome, erythema nodosum, Lambert-Eaton syndrome, palmar fasciitis, panniculitis, eosinophilic fasciitis. And other unclassified syndrome might be one of paraneoplastic pathogenic lesions like reflex sympathetic dystrophy, lupus-like syndromes, recurrent polychondritis, multicentric reticulohistiocytosis, and oncogenic osteomalacia. Regarding to pathogenesis of paraneoplastic rheumatic disease, there is many hypotheses, and the most important 3 hypotheses. 1, initiative factor that include bacterial factor, viral factor, and radiation. 2, toxins might be produced by the tumor cells which trigger inflammation. And this toxin might be due to degradation and damage of the nuclear protein of the cells during chemotherapy or during a neoplastic process. 3, paraneoplastic rheumatic disorder is mediated by hypersensitivity reaction. This is a rare, the prevalence of paraneoplastic rheumatic disorder is a rare disorder, and certain studies listed as approximately 15% of patients with cancer develop paraneoplastic disorders as a result of tumor-derived biologic mediators like hormones, peptides, antibodies, cytotoxic, lymphocytes, autocrine and paracrine mediators. Paraneoplastic arthritis, as it divided into carcinoma polyarthritis, and this presented as rheumatoid arthritis, hypertrophic osteoarthropathy, amyloid arthritis, secondary hyperuricemia, and gouty arthritis. The prevalence, as I mentioned, is rare, and the age of onset generally reflects that of association with malignancy. Most of reported cases, the age of incidence ranged between 43 to 76, with a median of 61. And most of cases precede the diagnosis of cancer by 1 to 20 months. The first subject of arthritis is carcinomatous polyarthritis. Usually it is a seronegative inflammatory arthritis and mostly migratory in nature and type of arthritis, and sometimes maybe it is a first sign of existent malignancy. Pathogenic factors include immune mechanism such as hormones, cytokines, peptides, antibody, and cytotoxic lymphocytes. Mostly associated with breast, lung, colon, ovarian, gastric, oropharynx cancer, as well as esophageal tumors and lymphoproliferative diseases. As we said, about 12 months before the development of the tumor might be precede the tumor. Here's a table differentiation between paraneoplastic arthritis and rheumatoid arthritis. Usually, paraneoplastic arthritis occur in advanced age, while rheumatoid arthritis in 35 to 50 years old. Usually, the paraneoplastic arthritis, the onset is acute, while rheumatoid, acute or subacute, or sometimes chronic onset. The type of arthritis in paraneoplastic arthritis is migratory and asymmetrical, and as we know, in rheumatoid is additive, symmetrical. In paraneoplastic arthritis, the lower extremities joints are mostly involved rather than the small joints of the hands and wrist, like in rheumatoid arthritis. The rheumatoid factors and rheumatoid nodules are absent in paraneoplastic arthritis, while in rheumatoid arthritis, of course, it is positive. The family history in rheumatoid are positive sometimes, and there is no family history in paraneoplastic arthritis. The deformity and erosions, which is a cardinal feature of rheumatoid arthritis, is not present in paraneoplastic arthritis. Usually, the rheumatoid arthritis respond very well to nonsteroidals and corticosteroid and DMARDs, while in paraneoplastic arthritis, there is no response to traditional therapy, and there is a good or a good response or a cure with successful treatment of malignancy in paraneoplastic arthritis, while in rheumatoid there is no malignancy as well. Here is case reports regarding paraneoplastic arthritis. This report, rheumatoid arthritis-like syndrome presenting symptoms of malignancy, reports of 3 cases and review of the literature. Recent onset arthritis might be an early manifestation of an occult malignancy. 3 patients are described, 1 with carcinoma, primary site was unknown, and 1 with out-cell carcinoma of the bronchus, and the other 1 with breast cancer. The presenting symptoms of their disease was polyarthritis. 2 of the patients were seropositive, and the arthritis regressed following the removal of the tumor. Awareness of paraneoplastic arthritis, especially if its appearance is exclusive or in relatively old age, should caution the physician of the possibility of a potentially curable but hidden neoplasm. There is many cases reported from literature here, rheumatoid-like polyarthritis as a presenting feature of metastatic carcinoma, a case presentation and review of the literature. This is published in Clinical Rheumatology in 2003. And migratory polyarthritis as a paraneoplastic syndrome in a patient with diffuse large B-cell lymphoma, a case report, which is published in 2018. This report revealed diffuse large B-cell lymphoma is the commonest histological subtype of non-Hodgkin lymphoma and typically presents as a rapidly enlarged lymph nodes, mass, and B symptoms. It is usual for diffuse large B-cell lymphoma to present as carcinomatous polyarthritis, which is a type of paraneoplastic arthritis. Other case report, which is published which is done in Vincent University Hospital, Dublin, in Ireland, 2015, revealed that migratory polyarthritis as a feature of occult malignancy. 2 cases reported and a review of the literature. 80-year-old female who presented with a 3-day history of right-sided shoulder pain and associated fever. Patient described asymmetric migratory joint pain over the preceding 3-week period, involved left wrist, knees, and right shoulder. It was not responded to non-steroidal anti-inflammatory drugs, and subsequent mammogram revealed a 3.5 centimeter irregular hypoechoic mass, highly suggestive of malignancy. This was confirmed after tissue biopsy with microscopy revealing a papillary carcinoma. The second subject of paraneoplastic arthritis هو hyperatrophic osteoarthropathy. HOA is classified as either primary, which is either primary or secondary. In this figure, we can find the primary, which is usually idiopathic, and the incidence 3 to 5%, while the secondary, the incidence 95 to 97%, which is divided into either generalized or localized form. When it is localized, that involve 1 to 2 limbs, in case secondary to patent ductus arteriosus, infective arteritis, aneurysms, and hemiplegia, while in generalized form, it is secondary to pulmonary, cardiac, hepatic, gastrointestinal, pleural, and mediastinal carcinoma. HOA is mostly associated with lung adenocarcinoma, and the prevalence varies between 6 to 12%. The classical disease triad for HOA is the combination of oligo or polyarthritis, clubbing in the toes and fingers, and periostitis at the distal ends of the long bones. Rapid progression is seen with this disease, which is related to malignancy, and the arthritis usually affect the metacarpophalangeal joints, knees, ankles, elbows, wrists, and proximal interphalangeal joints. Usually it is symmetrical and painful. However, the synovial fluid analysis shows no sign of inflammation. The periostitis usually characterized by deep localized bone pain, and the pain especially prominent at the distal part of the lower extremities, and typically increases during movement and decreases when the legs are elevated. Also, skin manifestation might be seen in patients with HOA, like thickening of the skin at the forehead and the neck, as well as gynecomastia. The laboratory finding in patients with HOA, the ESR is elevated, and the alkaline phosphatase also may be higher in cases, especially in cases with periostitis. The X-ray usually reveal symmetrical periostitis in the long bones. Scintigraphy abnormalities may precede the radiographic findings. Although pain is relieved by non-steroidal anti-inflammatory drugs, a cure is only possible by treating the underlying neoplasm. And this is also a case report which is published in Annals of Rheumatic Disease in 2006, that hypertrophic osteoarthropathy associated with gastrointestinal stromal tumor. HOA is a condition characterized by digital clubbing, polyarthralgia, periostitis, occasionally arthritis, and cutaneous sign of autonomic disorder, sweating, flashing, blushing. In the industrialized world, 90% of cases are associated with an underlying malignancy, usually a pulmonary neoplasm, but also cardiovascular and gastrointestinal diseases. Here, in the case described, patient presenting with HOA as the first manifestation of the gastrointestinal stromal tumor. And also this is a case report from Annal Saudi Medicine, diagnosis hypertrophic pulmonary osteoarthropathy due to carcinoma of the right lung. This is the X-ray of the right lung showing the radiopaque opacity in the lung, and here the femur and the tibial and fibular periostitis by X-ray, and you can see the X-ray of the knees that the knee joints is intact. There is no narrowing of joint space in HOA. The third arthritis that is included in paraneoplastic arthritis, it is amyloid arthritis, which is generally described in patients with multiple myeloma. Arthritis characterized by monoclonal light chain accumulation at synovium and typically involve the shoulder, knees, wrist bilaterally and relatively painless. Synovial effusion are non-inflammatory and contain amyloid deposit, and some other manifestation which include carpal tunnel syndrome, subcutaneous amyloid deposit, and macroglossia, cardiomyopathy, nephropathy are other manifestation. The diagnosis, bone marrow examination is confirmed the diagnosis of amyloid arthritis. serum electrophoresis by detecting the M band, and urine electrophoresis and detection of Pence-Jones protein. Biopsy of the synovium is crucial for the diagnosis, and paraneoplastic arthritis responds to the treatment of multiple myeloma. Here also, many case reports reported that amyloid arthritis simulating rheumatoid arthritis in 5 patients with multiple myeloma, and amyloid arthropathy mimicking seronegative rheumatoid arthritis in multiple myeloma. This is a case report and review of literature. And this case report also at a 48-year-old patient with oligoarthritis of the knee having excluded spondyloarthritis and rheumatoid arthritis. Amyloidosis mimicking rheumatoid arthritis. This is an old case report published in 1998. The last, paraneoplastic arthritis, which is secondary hyperuricemia and gouty arthritis. As we know, gout is the most common articular inflammatory disease, and it is usually resulted from deposition of monosodium urate crystals in the synovial fluid and other tissues that characterized by hyperuricemia, and the men are mostly affected than women. Usual presenting features is monoarticular arthritis involving the big toe or involving the first metatarsophalangeal joint in 90%, but 10% of patients can have polyarticular presentation, causes diagnostic confusion with rheumatoid arthritis. The prevalence of gout is increasing worldwide, and so during the past few years, the association between gout, hyperuricemia, and cancer have sparked a lot of research. Hyperuricemia and gout are mainly associated with hematological malignancies like leukemia, polycythemia vera, lymphomas, but they may also develop as a result of the rapid lysis of cell after chemotherapy. It results from the breakdown of nuclear proteins, leading to increased blood levels of hypoxanthine and xanthine. These compounds are degraded into uric acid by the enzyme xanthine oxidase. The severity of gout changes with the severity of the underlying malignancy, liver involvement, and presence of hypercalcemia. This features increase the severity of the gouty arthritis. Hyperuricemia can be prevented by adequate hydration and uric acid lowering drugs before chemotherapy. This is a case report of a girl, 2.5 years old, presented with hyperuricemia and gouty arthritis. And other reports, acute gout associated with chronic myelogenous leukemia, chronic myeloid leukemia presenting as gout. This is a 53-year-old man presented with gouty arthritis. A physical examination and hematological and biochemical test showed that he had chronic myeloid leukemia. He was treated with allopurinol, hydroxyurea, and analgesics. The arthritis subsided completely within 2 weeks. He continues in hematologic remission on interferon with no further recurrence of gout. Other reports, a high serum uric acid level is associated with poor prognosis in patients with acute myeloid leukemia. Also, pseudogout may be one of paraneoplastic arthritis, and here in this report, pseudogout, an autoimmune paraneoplastic manifestation of myelodysplastic syndrome. how to improve outcome and to improve early diagnosis of paraneoplastic rheumatism. We need a comprehensive history and physical examination and follow-up of the patient with unusual presenting manifestation. And we need a rheumatologist knowledge enhancement in order to know everything about paraneoplastic disorders that lead to early recognition of the disease, and work closely between rheumatologist and the oncologist to treat the paraneoplastic syndromes and the neoplastic disease itself. Also, here is a red flag. We should always make a red flags flattering and the presenting features, which, for example, unusual presentation of patient with his age. That means patient with gouty arthritis, if present in women, we should put a question mark and we ask for further investigation, further follow-up of the patient. Genders, for example, the age of the patient, we should ask for the age incidence of the patient. That means in childhood hyperuricemia, it is a red flag for the occurrence of gouty arthritis. A patient with joint involvement, unusual joint involvement, it is also a red flag in diagnosis. Patient with systemic manifestation or patient with unresponse to traditional treatment. All these are an indication for good and thorough follow-up and examination of the patient to recognize the diagnosis. Paraneoplastic arthritis, in summary, paraneoplastic arthritis refers to symptoms caused by a malignancy, but which have not directly related to a tumor or its metastasis. Paraneoplastic arthritis caused by soluble factors produced by tumor cells or are the consequence of an immune reactions against these cells. Arthritis and other musculoskeletal manifestations may be presenting features preceding the neoplastic disease, and it is predictive signs of an undiagnosed malignancy. Unusual presentation of a polyarthritis or other rheumatic manifestations, if it is unresponsive to standard therapies, should trigger doubt and lead to consideration about a possible underlying malignant process. Carcinoma arthritis remains a diagnosis of exclusion, and positive serological tests such as rheumatoid factor may be misleading. The rheumatologist is frequently the first specialist contacted by a person with paraneoplastic musculoskeletal symptoms. Rheumatologist knowledge of the clinical appearance of each paraneoplastic rheumatic disorder is mandatory because early recognition allows for a timely diagnosis and potentially life-saving therapy. Thank you for listening. Thank you for everybody.
شكرا جزيلا دكتور عقبة على المحاضرة البديعة جدا رائعة. شكرا جزيلا. وشكرا للأخوان أيضا دكتور شبيب ودكتور أثير على المحاضرات البديعة. أعتقد الآن جاء الموعد أنه نجاوب أسئلة المشاركين في هذه الندوة. Thank you. قبل ما أبدي بالأسئلة هناك لينك إذا تحبون a feedback form. If you go to the link and when you click on the link, just if you put your name as you wanted on the certificate, and also there's a short feedback to help us really to improve our practice in the future. So if you have, like, it will take only 1 minute or 2 minutes, and also it will help us to send you the certificate to your email. So please make sure your email is right there. I have till now collected 10 questions. Before that, إذا ممكن نسأل سؤال أريد جواب بالعربي. إحنا دائما غالبيتنا نشكي من أمراض يعني أوجاع مفاصل، أوجاع عضلات. فالسؤال الأول إلى دكتور شبيب، متى تنصح الشخص الذي يشكو من أوجاع في العضلات أن يراجع طبيب العائلة؟
شكرا جزيلا مجددا على تفضلكم بدعوتنا، وأيضا شكرا جزيلا للتعليقات من الأخوان وللمحاضرات القيمة. بالنسبة لسؤالكم الكريم، يعني حسب تعتمد على عمر الشخص، هل لديه أعراض أخرى، هل لديه أمراض أخرى، بس بالطبع كل خاصة من الأعراض تأخذ مدة أطول من المتوقع. يعني أنت إذا عندك ألم عضل، واحد عنده ألم عضلي يتوقع يطول أيام أسابيع، بس إذا يطول مدة أكثر، خاصة إذا عنده ويكنس، يعني هاي ضعف بالعضلات، هاي مهم جدا يعني، وخاصة بحالة قلنا التهاب العضلات مايوسايتس، مثلا إذا ضعف من واحد مثلا هو جالس على الارض ويوقف، او عنده مثلا واحد من الشخص يصعد درج يلاحظها صعوبه، هاي مهمه جدا. بهل واحد باسرع وقت يجب ان يراجع بها. لكن اذا بس مجرد الم بسيط، ماكو اعراض اخرى، ماكو فقدان وزن، ماكو اعراض بالجهاز التنفسي، ماكو اي اعراض اخرى، ماكو ضعف بالعضلات، يعني واحد يقدر يتحملها مثلا وياخذ بعض المسكنات الى ان شاء الله تاخذ وقتها وتروح. بس اذا الاعراض تطول، او خاصه اذا صارت وياها عده اعراض اخرى لامراض اخرى، خاصه اذا ضعف بالعضلات، فذاك الوقت لا، باسرع وقت يجب المراجعه.
شكرا جزيلا دكتور شبيب.
شكرا جزيلا.
أوجاع المفاصل، متى تنصح المريض أو الشخص السليم لكن يشكو من أوجاع مفاصل أن يستشير الطبيب؟
عفوا، المن السؤال؟
لك دكتور رفيق.
شكرا جزيلا. طبعا يشبه جواب دكتور شبيب. احنا هذه الاعراض اوجاع المفاصل، في الاوجاع الوقتيه اللي منها كثير حركي، خصوصا وجع الركبه، يعني كثير عندهم بالسلالم بالصلاب، هذه يصير عندهم وجع. هذا الوجع اللي احنا نصيح له الوجع الحركي، دائما ياخذ عده ايام، وقد يخف مع بروحه ومع مسكنات او مع بعض خلينا نقول تفادي بعض الاشياء. وكذلك الكتف ايضا يحصل بكثير، وكذلك القدم يحصل الام كثيره. فالم المفاصل ايضا يعتمد على النمط والمكان والشده. غالبا طبيب المفاصل يريد يشوف لما في تورم انتفاخ، هذه علامه مهمه. في العاده احنا الامراض خلينا نقول التهابات المفاصل عندنا وقت زمني 4 إلى 6 أسابيع. اذا المريض ما تحسن الالم بتاعه يفترض به يزور طبيب المفاصل، لان المشكله قد تكون التهابيه. لكن مع التورم قد نشوفه حتى قبل هذا، نشوفه ممكن خلال اسبوع اسبوعين. في عندنا حتى يمكن في بريطانيا في اللي يصحوا لها الايرلي ارثرايتس، كنا المريض مثل هذا نحاول نشوفه قبل اسبوع، يعني خلال اسبوعين لازم نشوفه. هذا في التارجت. فهذا غالبا اما في تورم وانتفاخ، اما في تيبس في الصباح بشكل ملفت للنظر ساعه او اكثر، واما الجي بي مثلا عمل له فحص وشاف عنده التهاب السي ار بي او الاسعار عالي. على ضوء هذا من المهم نشوفه من وقت، لانه كل الدراسات قاطبه تقول ان التشخيص المبكر والعلاج المبكر يمنع الضرر اللاحق من خلال خلينا نقول تشوهات المفاصل الاخرى وغيرها. بس كثير من ما زال يبقى الشائع هو الآلام الحركية. الواحد ياخذ مسكن ويريح نفسه اسبوع، شاف نفسه لا ما جاي تمشي الامور، عود يفكر يجي
شكرا جزيلا دكتور رفيق. دكتور، احنا دائما نشوف المالتيبل مايلوما تشخيص متأخر بسبب أنه شخص يشكي من أوجاع العظم، لكن ينتظر أنه يقول لك هذا يمكن عضلات مو عظم. إيش تنصح إذا شخص كان يشكي من ألم في العظام، خاصة مثلا عظم الحوض أو عظم الظهر أو يعني فقرات قصدي أو الكتف، كيف تميز العضلة عن عظم العظم، ألم العضلة عن ألم العظم؟ يعني
نعم. شكرا دكتور على السؤال. طبعا نقول مصدر الألم مختلف، لأن المريض من يتحدث عن مصدر ألم يقول لك الورك يوجعني، بس مصدر الألم قد يكون هو مو الورك، هو العصب النازل من الفقرات القطنية على الورك. يعني إذن السورس اوف بين ممكن يكون نيورولوجيكال، ممكن يكون ماسكولار عضلي، ممكن يكون بون، ممكن يكون جوينت. إذن بالعربية أو بالعامية شو نقول؟ انطي الخبز الخبازته، روح على الدكتور المختص وهو يعرف إذا كان الألم متكرر، مهم جدا، وإذا كان الألم مستمر، وإذا كان الألم ما يطيب رغم أنه أنت تأخذ له بوتنت أنالجيسيا، وإذا كان الألم يعيق النوم عندك. هذه النقاط هي مهمة جدا أن يلاحظها المريض نفسه. إذا شاف الألم ويا فيفر، إذا شاف الألم مثل ما تفضل دكتور أثير بأرثرايتس، مو أرثرالجيا، يعني مو just pain, there is a cardinal sign، أكو ريدنس، هذه كلها ريد ماركس، أو يعني ماركس مهمة أن تدعو المريض أن يستشير الطبيب المختص.
شكرا جزيلا دكتور أحمد. سؤال من دكتورة ذكرى: بعد اصطدام سيارتي الخاصة رجع البريك على قدمي، وقتها لم تكن قوية، ثم بعد فترة ليست بالقصيرة تسببت حشرة في تخثل لمدة شهر، تم إتلاف الأوعية العميقة، وكان هذا منذ سنة ونصف، ولكن بقيت كاحل القدم بأقل تعب تتورم، والآن تؤلمني في منطقة المفصل، والطبيب لم يشخص بالضبط هل هو أثر الصدمة، فتسأل عن ما احتمالات هذه الحالة وعلاجها. اختار دكتور أثير.
يعني ممكن انا ما فهمت القصه بالضبط، ايش اللي صار لما رجع
هو
البريك؟
هذه السيارة كانت
إيه.
سيارة البريك رجع ضرب رجلها بعد حادثة
زين.
السيارة. بعدها صار عندها ثرومبوسيس في الأوعية،
نعم.
يعني دي في تي، وبعد
إيه.
بقى الكاحل يورم ودار
نعم.
ألم. عندك
نعم. زين. هاي فيها تقبل اكثر من احتمال. احتمال واحد انه من رجع هذا هو دي في تي عمت عن المشكله، بس هي صار عندها فد ليجمنت سبرين بالانكر، وبقى هذا مثلا ما ريحت روحها بشكل كافي وبقى يوجعها، وبقى مثلا بالحركه يوجعها. هذا احتمال واحد، هذا بالفحص لازم نعرفه. بس اذا تمشي بالمشي اكو وجع، معناها لحد الان اكو فد نقول ليجمنت او تندن بين ريليتد بين، وذا هو منتفخ. هذا اذا الانتفاخ بالكاحل فقط. اما انتفاخ اذا مع القدم ايضا، ففي حاجه مرات يصيحوا لها بوست دي في تي سيندروم، واللي هو الفالفول نوت دي في تي ما ترجع لكامل طبيعتها، فيبقى يصير مرات تورم مزمن. هذا مش كثير، يعني قليل، ومو بالضروره يصاحبه الم، بس يبقى انتفاخ الى حد ما. ربما الاحتمال الاول قد يكون هو الارجح، يعني انه صار عندها فد ليجامنت بين او شيء.
شكرا جزيلا. السؤال الآخر من الدكتورة ميساء ناصر. العفو دكتور مصطفى إسماعيل. هذا السؤال إلى دكتور شبيب. Is there a reverse causality between DM and the malignancies, or is it just paraneoplastic syndrome?
شكرا جزيلا على السؤال. بالحقيقة هو الدكتور أحمد تكلم عن الموضوع، غطى فيما يتعلق بمشاكل المفاصل ويعني أمراض المفاصل مع المالجنسيز، لكن بالنسبة حتى قسم منها ينطبق أكيد بالنسبة لمشاكل العضلات وأمراض العضلات بصورة عامة. لكن بالنسبة للدرماتومايوسايتس خاصة and malignancies يعني we know it's more of paraneoplastic association يعني rather than anything else. Although يعني يقول لك sometimes we don't know whether there's some underlying common mechanism to cause both inflammatory myositis and the malignancies, or حتى مثلا whether chronic inflammation over time can cause malignancy. We don't know. لكن هي على الأكثر هي paraneoplastic phenomena. وأنا مثل ما قلت بالمحاضرة يعني شايف عدة أنواع مختلفة من السرطانات. يعني من كنت حتى أتدرب إلى هالفترة من أخصائي عدة أنواع من السرطانات، وحتى أذكرها هم بالجديد مريض lung cancer يعني كان عنده presented as dermatomyositis ولنج كانسر، وبعدين سوينا له CT ثوركس ابدومين بلفس بالاحرى dermatologist سوى له، كان عنده cutaneous manifestations اكثر، وطلع عنده very early lung cancer، وبعدين هو هذا corrected يعني treated surgically والبيشنت يعني did very well حتى يعني just after removing the tumor. وanother lady ويا حتى breast cancer removing حتى البريست cancer و did very well حتى بعدين didn't require يعني long term immunomodulators or steroid. بصورة عامة it's more of paraneoplastic.
شكرا جزيلا.
شكرا.
دكتورة ميساء تسأل what is the screening program used for patient with DM and is CT scan or blood investigation included؟
أكيد. هو أول شيء أنت أهم شيء الهيستوري يكون مهم جدا. يعني إحنا هاي وحدة من السيدات كان عندها بريست كانسر، بس كانت معنا طبيبة سألتها المقيمة القدمى سألتها عندك مشاكل في يعني البريست، عاملة examination، فهي قالت قبل شهر أو شهر ونص صارت لاحظت عندي لامب ولحد الآن ما رايحة للجنرال براكتيشنر. فهاي مباشرة هي المقيمة مالتنا examined her وشافت بريست ماس، وبعدين بدت كل الستوري من هناك، يعني كانت بريست كانسر. فأنت أول شيء تأخذ detailed history أهم شيء. Another patient كان عنده hoarseness of voice, lady with bleeding يعني vaginal bleeding، فهاي الأمور أو rectal bleeding، فأنت كلها تعتمد أول شيء الهيستوري detailed history examination كذلك، وبعدين investigations. بس إذا البيشنت ما عنده أي أعراض أخرى suggestive of malignancy، ما عنده أي أعراض أخرى مثلا من اللي ذكرتها، ما فعلى الأقل واحد أكو قسم يقول لك أسوي مثلا chest x-ray و ultrasound scan of the abdomen، بس بصورة عامة إحنا نسوي أكثر شيء CT thorax abdomen and pelvis يعني على الأقل، وهذا يعطينا فكرة جيدة إذا أكو شيء أو لا. وطبعا بالإضافة إلى فحوصات الدم الأخرى هم تبين واحد عنده يعني مثلا هايبركالسيميا غيرها evidence of multiple myeloma، كلها طبعا أيضا مفيدة يعني بالفحوصات كلها يراد واحد يعملها مثل ما ذكرت بالمحاضرة. لكن بالنسبة لك radiological investigations يعني أنا أشوف CT thorax abdomen and pelvis فشيء جيد نعمله لكل المرضى with myositis.
شكرا جزيلا.
إن شاء الله يعني هذا يكون يجاوب على السؤال مال الأخت.
شكرا جزيلا دكتور شبيب. عندي سؤالين على
شكرا.
one of them is from Dr. Saad Karim. How could we discriminate between inflammatory myositis and steroids-induced myopathy in critically ill COVID-19 patients?
هذا السؤال المايوسايتس ولا للكوفيد؟
والله هو يجاوب واحد.
كان السؤال هو الدكتور شبيب اتصور،
لأن هو بالحقيقه يعني اذا الشخص كريتيكالي ال يعني مثلا انت تتوقع عند ما اعتقد بهالسرعه اللي صار عنده، يعني انت تبدي البيشنت تعطيهم هاي دوز ستيرويد اوكي، بس ما اعتقد بهالسرعه بحيث راح يصير عنده ستيرويد انديوست مايوباثي مثلا، مو بهالسرعه اللي يصير عنده راسا. فعاده خاصه البيشنت كريتيكال انت بعد ما ملحق ماخذ السايد افكتس بالنسبه للمسلز من الستيرويد، يعني عاده تاخذ شويه مده اطول. فيعني خاصة إذا أنت عندك patient presented with a يعني عندك a newly diagnosed patient with COVID وصار عنده يعني you think or you suspect myositis, so it's most likely هو viral induced myositis rather than steroid induced myopathy.
شكرا دكتور شبيب. بعدنا موضوع الكوفيد وهذا دكتور أثير. How to differentiate between rising CRP due to inflammatory storm and rising CRP due to secondary infection in COVID?
Yes, that's a good question because CRP is a common marker for both. We take case-by-case evaluation. When there is infection, if it is pneumotic patch, it will look different on the CT scan compared to the case, for example, we show. So if the picture is suggestive of pneumotic patch, that's one. Number two, if the CRP high, but the ferritin is not that high, that's against cytokine storm and in favor of pathogenic, like bacterial elevation of the CRP. Number three, we do test procalcitonin. I don't know it's available everywhere or not. It's very good differentiating. It still might go slightly up on inflammation, like any other markers. All with inflammation goes slightly up, but significantly up can tell us there is a bacterial infection. Number four, these cases, when we review them, they are already on antibiotic anyway. So we are not missing out. I mean, cytokine storm, even when we treat cytokine storm, we cover antibiotic. If there is no infection at the time, we need to prevent infection to happen later on the basis of where alveolitis area, it could subject to secondary infection. So we take on precaution all these. It's important if you say, well, if you have someone with bacterial infection and not storm, is it harmful to give tocilizumab? No, it's not that much harmful. That's also on the other side of the equation. But yes, we look at the CRP blood culture, of course, and all cultures that's part of the procalcitonin. I rely on it to somehow it can't differentiate.
Thank you دكتور أثير. سؤال من دكتور أحمد الداهري. يقول لك I have few patients on DMARDs who caught COVID-19, yet they did much better than the average patients. أنا أيضا شفتها بعض المرضى. I suspect the DMARDs is putting a cap on inflammatory response and prevents the cytokine storm. Dr. Athir.
Yes, as we said, first of all, we are concerned, previous advice to stop this medication. And as we said in the lecture, we don't stop the medication. Do they do better? According to the concept he mentioned, probably because there are trials on other biologics on COVID cases, the anti-TNF. So they might, let me say, might play part in minimizing or preventing cytokine storm. But the DMARDs have not been studied thoroughly. We studied biologics, but we didn't study DMARDs. So I cannot give definite answer, but the observation are potentially correct. That's all what I can say.
يعني احنا ايضا بالحقيقه يعني عندنا هوايه مرضى هم على DMARDs ثيرابي بايولوجيكس، بس مدى نشوف مثلا فد اعداد كبيره منهم very ill لو مثلا died with COVID. اوكي مع الاسف اكو بعض منهم يعني اصيبوا به وتاذوا حتى قسم توفوا، بس مو باللي شيء واحد يتخيل كانه هاي الميديكيشنز كانه very strong immunosuppressants and that's it يعني you will get COVID and if you get COVID you will pass away يعني you will die تتوفى، يعني مو بهالشكل اللي يتصور، بحيث ناس عندنا مرضى كثيرين جدا يعني حتى ستوبت الميديكيشنز مالتهم. يعني قبل كم يوم تكلمت مع مريضة سنة كاملة قاطعة البايولوجيكس مالتها الانجكشنز يعني هاي مشكلة، يعني الكثيرين وقفوا وصارت عندهم مشاكل بالمفاصل وبالعضلات وغيرها وأعراض جانبية وأعراض أخرى للأمراض بسبب توقف الأدوية مالتهم، وهذا غير صحيح. يعني تحس مثلا صار عند الناس رد فعل أكثر من اللازم في موضوع الأدوية الديماز والبيولوجيك ثيرابي.
فالنصيحة أنه يستمروا على أدويتهم، لأن احتمال مفاصلهم تأثر أكثر، احتمال التأثير يكون يعني صعب الرجوع إلى الحالة قبل التأثير أو الدمج اللي يصير.
بالتأكيد بالتأكيد.
يعني دكتور رافد إذا تسمح لي دكتور.
نعم.
دكتور، هو السؤال يعني المهم، كم مريض هو مثلا عنده connective tissue disease under DMARD and they undergoes مثلا risk with COVID-19. اكو دراسه؟ سؤال الدكتور اثير.
عفوا، سؤالك كم مريض على ذولا في الروماتولوجي الاينس؟
الروماتيك ديزيزز يعني اكو في الدراسه اكو significance؟
لا، الروماتولوجي الاينس real world data registry. That's the best you can get. It's not دراسة parallel that you try to see who is on it, who is not on it. ما عملوها بالشكل هذا. بس اكو registry اللي أنا contributed to the registry. and registry getting bigger and bigger في European وفي American both. هذا registry كل المريض any rheumatic disease and on any disease modifying or biologic has been registered, and look at the outcome, how many get COVID and what's the response to COVID. In general, they did not see difference on the pattern of people on disease modifying compared to the normal population. So these medicine neither get them worse nor get them much better. But this is not a study. This is a registry. That's the difference between a study and registry. So this is Rheumatology Alliance. Just tell us we are okay and safe to continue the medication. Still, people could stop the medicine for 1 week at the first viral illness. That's fine, but continue in general terms. So that's the best of evidence we can tell.
Thank you.
Thank you دكتور أحمد كثير. سؤال من زميلتنا دكتورة سحر عبد الرسول. للعلم طبعا دكتور سحر عبد الرسول راح تكون أحد المحاضرين في المحاضرة القادمة حول الريسيرش. مشكورة جدا دكتورة سحر. Good evening. Based on your experience, I think this is to Athir. Are you with or against the early use of anticoagulants with steroids in COVID?
Thank you دكتور سحر. طبعا دكتورة سحر معروفة للجميع ودورتنا هي ونحن فخورين بها. ما في أول شيء ما في دراسة. early use ما معنى early use بالviral phase بالcytokine storm phase or after improvement. No one can tell. Till now there are people they don't treat with anticoagulation. But based on my our practice, I get involved with all COVID at the time. Now we don't receive COVID patients. But our practice, we give them heparin in the hospital, and then we start to recommend to give them warfarin. Although the internal medicine, they only wanted to give 1 month, 1 month and that's it. Although my feeling 3 months is much safer. So that is mainly after the cytokine storm or with the cytokine storm, heparin and then warfarin after that. Is it evidence-based? No, it is just a risk assessment. There is no evidence-based or a study to tell us figures how good is this practice or bad. But this is based on a very worrying mechanism of the viral, let me say, post-viral inflammation, and also a couple of events that, one case collapse after discharge from the hospital and die, that's significant to warrant the practice. We need to prevent fatality. So that's how, and I know people in UK now, they use warfarin for a month as well. 1 month is more accepted. 3 months, I feel, is much safer. That's what I...
Thank you. سؤال من مؤيد عزيز. Is a comment, he said, in the UK, as you well know, patients are managed at home till the oxygen drops, oxygen saturation, or become exhausted. That means it becomes too late for immune modulators to have any effect.
Yeah.
Agree with that?
But I think that's a real problem because we did manage and we get our conclusion based on the policy in UAE. Anyone just positive come to hospital, even asymptomatic. So we have the time at that time, we have the chance to observe everyone, which is not the case in many countries, not the case in the UAE now, because they cannot admit everyone now. So it was the practice we did. I say all patients, COVID positive, daily CRP, fibrinogen, ferritin, and everything, and repeat chest X-ray frequently, CT scan whenever needed. That was help us to have a grip on these cases. And that's what made them like very early treatment and improve dramatically. I agree with you. At home, they might go into the cytokine storm phase, yet they are not calling the emergency or not calling anyone, and they come to the hospital already later after that phase. That is, there is a question again about the controversy of tocilizumab, which I mentioned briefly. Those people, if you give them tocilizumab a bit late, it's not going to help much. That's one of the points we mentioned. If they start to have some organ failure one way or another, but it is NHS, I know it. It is a huge figure of cases there in UK, and I don't know how to solve it. I'm not the Prime Minister.
Yeah, okay. I'll tell you from my experience in our area, what we have done in Hertfordshire, we have what's called virtual wards. So any patient above 65, COVID positive with symptoms, respiratory symptoms, we admit them to these virtual wards. It means that we do like regular phone calls to them, sometimes video calls. We support them with we deliver to them oximeter. So they check their saturation at home. And also we send them nurses to take a blood regularly. So we check the D dimer for them, and we check other indicators, CRP and white cells and others. So we can start either taking to hospital or start oxygen at home or start dexamethasone for them early. I think that's helped much.
That seems, let me say, practical in the situation. It seems, yeah, it would help a good number of cases.
Question from Dr. Nadia Ziada. We notice in the primary care now, or generally now, the Royal College advised against or stopped giving the intra-articular steroids injections. I don't know, Dr. Shabib, you are now. Is there anything behind that?
لا في بداية البانديميك يعني خاصة احنا بالشهر الرابع يعني نهاية الثالث الرابع وكذلك حتى قسم من الخامس ما كنا نعطي انترا ارتيكولار انجكشن اوف ستيرويد يعني ستيل بعد المرض الجديد يعني كان يعني ما معروف عنه كل شيء وطبعا ولا نزال نعرف عنه ما نعرف عنه كل شيء لكن كانت يعني حالات كثيره ومن جمله الامور حتى واحد يخاف bring patients to the hospital يعني non covid patients فيعني we stopped doing the non urgent one لكن يعني we continue to do the urgent one يعني هذا
regarding infection control and prevention, social distancing and avoid unnecessary risk if it is not urgent.
بالضبط بس هسه احنا يعني لا بالفتره الاخيره لا بالبيك الثانيه لا يعني مو مثل البيك الاولى لكن هم نحاول كالروتين انجكشنز الروتين انجكشنز ما نعملها لكن اي شيء مثلا urgent يعني اوكي we have to do it لكن still يعني مثلا patient عنده mild osteoarthritis symptom asking for joint injection لا هاي ما نعملها يعني هو for safety reasons you don't want to mix people together لكن still for urgent indications no we still do them يعني if you want to do it if you have if the patient needs it okay we have to do it.
Okay, thank you, Dr. Shabib. Dr. Uqba, as a rheumatologist, what do you think? This is a question from Dr. Kawthar Nasser or Nazar Nassar. What do you think the treatment for chronic rheumatoid disease? Do you think steroids as intra-articular injections give the patient relief or huge relief? Or is there a place for it?
طبعا if there is a monoarticular arthritis and it is indicated for local injection or stiffness, complete stiffness and complete stiffness of range of motion is decreased of single joint, we can do local injection for this joint.
Thank you. سؤال من الدكتورة خالدة عباس مهدي. What is the relation, or is there a relation between angiotensin inhibitor and knee joint pain? I haven't heard about that. Someone can help in this question.
ربما قصدها يعني she takes medicine angiotensin.
Yes, they are on angiotensin, I think, as maybe antihypertensive.
I'm not sure, but many medicine, occasionally arthralgia part of their side effect. She is very unlucky. I mean, angiotensin in general is not a famous one to cause arthralgia.
Okay.
But if she is one of the unlucky, have this type of let me say side effect. But there is no well-known, at least to me, I don't know, Dr. Akba or Dr. Shabibi, they know something. Not something known to me that there is a direct relationship.
Certainly, يعني when patient comes to you, you check a list of medications, but when you تشوف مثلا patient on فرضاً ramipril, for example, and suffering from joint pain, يعني you don't عادة think of it يعني as a cause of the joint pain. يعني مو common. أكو medications common, for example يجيك patient on statin عنده myalgia، قد آلام أخرى تتوقع يجوز يعني could be related, but certainly with الانجيوتنسين inhibitor لا، يعني not common at all.
الأخ زياد، الأستاذ زياد شلتار، أخصائي علاج طبيعي، يقول ما رأيكم في هذين النقطتين؟ الالتزام بأخذ الأدوية في نفس الوقت يوميا يساعد جسم المريض على التكيف مع الروماتيزم بشكل أفضل، وكذلك الحمام البارد الصباحي حتى إذا كان حمام سريري يساعد على تسريع حركة الجسم. طبعا أخذ الأدوية في موعدها ثابت مفيد جدا. الحمام البارد في الصباح
والله اكو يعني patients مثل مع inflammatory arthritis يجونا يقول لك يعني أنا أفضل آخذ حمام بارد صباحاً make my symptoms better، يعني يحسن قد، لأن من الحرارة مال inflammation اللي تصير عنده، الألم مال المفاصل، قد يشعر مثل حمام بارد يفيده. يعني قد البعض يفيد، اكو قسم بالعكس ما يستجيبون لهالشيء. لكن يعني بالتأكيد أخذ الأدوية بموعدها مثل ما تفضلتوا هو مهم جدا. يعني
هو مو بالضرورة حمام بارد دكتور، آسف على المقاطعة، يعني بس الكولد بادز واحدة من الفيزيوثيرابيوتيك tools. cold pads on the affected joint for example، مثلا إذا كان عنده الركبة فيها arthralgia or arthritis، cold bags، يعني مو بالضرورة أن يكون حمام بارد.
أكيد أكيد أكيد.
شكرا جزيلا. هناك مداخلة من الدكتورة رندا صادق. Sorry but there was no announcement prior to this meeting. هذه إليه. طبعا إحنا لأن محاضرات تقريبا أسبوعية نحاول نعلن كل أسبوع بأسبوعه حتى ما تصير كونفيوجن. أنا أرسل إيميل لكل المشتركين أعضاء الجمعية والمشتركين أصدقاء الجمعية، نعلنها على الفيسبوك هنا أيضا على شكل إيميل. لذلك نعمل الجوجل فورم حتى تكتبون إيميلكم حتى نخليكم على الميلينج ليست. فآسف أخت رندا إذا يعني ما وصلك الأناونسمنت هذه المرة، لكن إذا الإيميل مالك موجود أكيد يوصلك، وإذا ما موجود ممكن تملين الاستمارة اللي موجودة اللي فيها فيدباك حتى نخليك على الميلينج ليست للجمعية. وشكرا جزيلا. أعتقد ما عندنا بعد أسئلة، مشكورين جاوبتوا كل الأسئلة اللي وصلتنا. وإحنا نأتي إلى نهاية ندوة هذا اليوم. نعم ماك سؤال. أحب أشكر الأخوة الأعزاء أخصائي المفاصل والروماتيزم، دكتور شبيب المظفر، دكتور عقبة يوسف الناصري، الدكتور أثير الأنصاري، على محاضراتكم الرائعة ومشاركتكم لنا ووقتكم الثمين اللي يعني أنا أعرف أنتم اليوم جمعة ويوم راحتكم. شكرا جزيلا لكم. وأشكر أيضا الأخوات والأخوة الذين شاركونا هذه الندوة، ونلقاكم إن شاء الله في الجمعة القادمة في نفس الوقت، راح تكون عن الريسيرش papers or how to publish papers. It will be a very good also for the board students as well, and the new doctors, and also for doctors. The research is both for everyone. And the week following that will be on the bariatric surgery, and it will be very good conference as well. If you have any ideas or if you want us to talk about any subject or to explore any subject, please email us or put a note for us, and we are happy to do that for you. Once again, thank you very much indeed. شكرا جزيلا لكم جميعا. أتمنى لكم عطلة نهاية أسبوع سعيدة، وإن شاء الله نشوفكم بخير وصحة وسلامة. تحياتنا لكم جميعا. شكرا جزيلا.
دكتور رافد،
شكرا جزيلا لكم جميعا.
بارك الله
فيك.
شكرا دكتور رافد.
شكرا جزيلا. شكرا استاذ عبد الله. شكرا دكتور صاحب.
شكرا
للاخوان والاخوات ما ذكرنا معهم.
تشكر دكتور رافد.
شكرا دكتور راضي رافد الورد.